My name is Dr. Blachy Dávila Saldaña. I'm a pediatric hematologist-oncologist based in Washington, D.C. I exclusively treat patients with non-malignant disorders who need a bone marrow transplant. So, in my institution, about 80% of the patients I see have primary immunodeficiencies. And then I also see other patients with non-malignant disorders, such as bone marrow failures or metabolic disorders. In my 10 years of experience, I would say I've treated 15 to 20 patients with primary HLH, many of whom have been infants of 1 year or less. Having said that, there have been some patients aged between 14 and 18 years, and the case I'd like to share today fits into this category.
Indication and usage. Gamifant, emapalumab-lzsg, is an interferon gamma-blocking antibody indicated for the treatment of adult and pediatric, newborn and older, patients with primary hemophagocytic lymphohistiocytosis with refractory, recurrent, or progressive disease or intolerance with conventional HLH therapy. Important safety information. Infections. Before initiating Gamifant, patients should be evaluated for infection, including latent tuberculosis. Prophylaxis for TB should be administered to patients who are at risk for TB, or known to have a positive purified protein derivative test result, or positive interferon gamma release assay. During Gamifant treatment, patients should be monitored for TB, adenovirus, Epstein-Barr virus, and cytomegalovirus every 2 weeks and as clinically indicated. Patients should be administered prophylaxis for herpes zoster, pneumocytosis jirovecii, and fungal infections prior to Gamifant administration. Please stay tuned at the end of this video for additional important safety information for Gamifant.
This patient was a 15-year-old male called Mack. He presented to an external hospital with headache, fever, nausea, vomiting, and lymphadenopathy, symptoms that were consistent with the primary EBV infection. So at this stage, he was treated accordingly. He was discharged from the hospital and went home. But then about a week later, he returned to the same ER with worsening symptoms, and he was admitted to the ICU. Based on his symptoms, hematology was consulted, and a range of tests were carried out. Lab values suggested primary HLH, and 6 out of 8 HLH criteria were met. A range of additional tests were performed to help confirm the clinical diagnoses and to identify the underlying trigger. The flow cytometry and genetic testing confirmed primary HLH triggered by XLP1, or X-linked lymphoproliferative disease. XLP is characterized by an extreme vulnerability to EBV. Later on, a CT scan of the chest, abdomen, and pelvis was carried out, which is important because HLH has been reported to present concurrently with lymphoma, and so we wanted to rule out possible malignancies. In terms of the initial treatment, Mack received dexamethasone at a starting dose of 10 milligrams per meter squared per day, along with rituximab. A few days later, etoposide was initiated concomitantly with dexamethasone. To mitigate the HLH-induced cytopenias and the effects of chemotherapy on the platelet count, multiple blood transfusions were also administered. I'd say this upfront treatment approach was partially successful. Mack's fever resolved, and he was able to leave the ICU. But disease activity remained significant, and many of his symptoms were still present. With the etoposide and dexamethasone, we were still seeing very high levels of soluble IL-2, ferritin, pro-inflammatory cytokines, and CXCL9 expression. Alongside this, we had some concerns about toxicity with the continued use of steroids and chemotherapy, especially thinking ahead to the bone marrow transplant that was to come. Because of this, we were interested in taking a targeted treatment approach. And that's why we chose Gamifant, which targets and neutralizes interferon gamma. So we initiated Gamifant on day 33. As we did so, we closely monitored for side effects and signs of fatal and serious infections by pathogens favored by interferon gamma neutralization. Around a week later, Mack's condition stabilized. We saw a resolution of his primary HLH symptoms, including fever, and normalization in a range of lab values. Alongside this, transfusion independence was achieved and his EBV resolved. Since he was responding to treatment, we reduced the dose of both Gamifant and dexamethasone. But then some CNS complications arose, in the form of optic nerve vasculitis. This led us to increase the Gamifant dose, add in intrathecal therapy, and also administer 2 doses of cyclophosphamide. As we prepared Mack for allogeneic transplant, we continued to administer Gamifant, intrathecal therapy, and low doses of dexamethasone. The last dose of Gamifant was administered the day before transplant. After a few weeks of conditioning, Mack was able to successfully undergo transplant. We were pleased to see in the chimerism blood test that 100% donor cells were achieved by 30 days post-transplant. His HLH parameters and organ function were all normal as well. 3 months following the transplant, Mack developed post-transplant lymphoproliferative disorder. But fortunately, this was fully resolved within 2 months. Despite this tough journey for a 15-year-old to go through, I'm pleased to say that Mack has been able to get back to his daily activities. He's back in school, playing sports, and able to travel. He's a great kid.
Additional important safety information. Increased risk of infection with use of live vaccines. Do not administer live or live attenuated vaccines to patients receiving Gamifant and for at least 4 weeks after the last dose of Gamifant. The safety of immunization with live vaccines during or following Gamifant therapy has not been studied. Infusion-related reactions. Infusion-related reactions, including drug eruption, pyrexia, rash, erythema, and hyperhidrosis, were reported with Gamifant treatment in 27% of patients. In 1/3 of these patients, the infusion-related reaction occurred during the first infusion. Adverse reactions. In the pivotal trial, the most commonly reported adverse reactions, greater than or equal to 10% for Gamifant, included infection, hypertension, infusion-related reactions, pyrexia, hypokalemia, constipation, rash, abdominal pain, CMV infection, diarrhea, lymphohistiocytosis, cough, irritability, tachycardia, and tachypnea. Additional selected adverse reactions, all grades, that were reported in less than 10% of patients treated with Gamifant included vomiting, acute kidney injury, asthenia, bradycardia, dyspnea, gastrointestinal hemorrhage, epistaxis, and peripheral edema. These are not all the possible risks associated with Gamifant. Please see the full prescribing information at www.gamifant.com/pdf/full-prescribing-information.pdf.